A 68-year-old woman come to the office due to the pain and stiffness in her finger. The pain has been presented for 5 years and is worst as proximal and distal interphalangeal joints. Medical history is notable for type 2 diabetes, grave disease treated with radioiodine therapy, non-alcoholic fatty disease, and hypertension. Okay, vital signs are normal, BMI is 34, and the patient is in no acute distress. The image below shows examination findings in the hand, but the remainder of her physical examination is mostly serum rheumatoid factor is negative. Which of the following? Okay, this is the examination finding. And what we are having, the option, which of the following is most likely the diagnosis? Which of the following is most likely the diagnosis? Calcium pyrophosphate crystal deposition disease, gout, neuropathic arthropathy, Charcot joint, osteoarthritis, seronegative rheumatoid arthritis. So anyone have any idea what it can be? The patient is 68-year-old. Stiffness, there is a stiffness in her fingers. The pain is present for 5 years. Worst as proximal and distal interphalangeal joints. She has a history of diabetes. Grave disease has been treated, and non-alcoholic liver disease as well as hypertension. Vital signs are normal. Her BMI is she's obese almost. The patient is no, there is no distress. Okay, fine. And her physical examination is normal. Everything is normal except she is having diabetes, hypertension, metabolic fever, and there's a stiffness, and it's for 5 years. And it's, interphalangeal and proximal joints. So anyone have any idea what is this? And this is the finding. Anyone? Okay, it's pseudo gout. Okay, fine. Anyone else? Wait, let me keep the chat here. So I can read. Calcium pyrophosphate crystals. Okay. If we just see this findings, what you can see? See, if you will just see, these nodules can be seen. You can see this nodule is here. Here is a nodule. See this such a big nodule here, and this one also there is a nodule. This, see, it's elevated. See the nodules. Can you see? Anyone have any idea what these nodules are? And see, it's for 68 years. Also, it's there. But if we just go, I don't know, I don't remember, but usually in gout, there is redness and pain, and extreme pain also is there. This in gout, pain is there, but the patient is is no acute distress. Like there is no acute pain. Like she's having no. Okay, so everyone is saying that it's A, calcium pyrophosphate deposition. Okay, so we will see. It's osteoarthritis. So it's osteoarthritis, and because we can see the patient has typical findings of osteoarthritis. Okay, fine, here it is labeled also. Bouchard nodes and Heberden nodes. See, these are the nodes, and the age was also positive, and she was having this pain, and stiffness was also there. In gout or pseudo gout, I don't think so. There is stiffness. Well, okay, fine. We just read. Okay, the patient has findings typical of osteoarthritis, including chronic pain, yes, stiffness, and bony enlargement of joints. Osteoarthritis is due to progressive non-inflammatory degeneration of articular cartilage, Associated changes may include subchondral cyst and bony outgrowths, osteophytes at the joint margins. Osteoarthritis is usually idiopathic phenomena of aging, but can occur secondary to acute or chronic joint injury and certain systemic disease. Okay, fine. This is one question I will just ask. Um, because of this is aging. Uh, if anyone will look the recording of yesterday's lecture, then you can see there is a disease which is often diagnosed late because it is asymptomatic. In most of the cases, it's asymptomatic, and we are asymptomatic, and it's often diagnosed late. We often miss the diagnosis. So just look at that and mention the group that which disease was that. Okay, osteoarthritis predominantly affects the large weight-bearing joints of the lower extremity, hips, knees, the small peripheral joints in the hands, and the cervical and lumbar spine. Prominent osteophyte formation at distal interphalangeal this Haberden nodes and proximal interphalangeal, which are nodes as seen in this patient, are strongly characteristics of characteristics of osteoarthritis. Okay, and everyone was saying this option A. Gout presents in most cases as an acute inflammatory monoarticular arthritis associated with edema, erythema, and severe pain. The first metatarsal tarsophalangeal joint and the knee are most commonly affected. Calcium pyrophosphate deposition disease, which is pseudo-gout, results from accumulation of calcium pyrophosphate crystals in the articular cartilage and synovial fluid. Like gout, pseudo-gout presents with acute monoarticular or oligoarticular arthritis, and involvement of small joint is unusual. Osteoarthritis causes chronic pain, stiffness, and bony enlargement of large weight-bearing joints of lower extremity. The small peripheral joints in the hands and the cervical and lumbar spine. Prominent osteophytes at the distal interphalangeal joints and proximal interphalangeal joints are characteristics of osteoarthritis. This one also we can see. Okay, where is the question number 13? Okay, the question number. Okay, the question number 13 is missing. I will just move to. Okay, now the next question. Question number 14. Okay, a 40-year-old woman comes to the office due to joint pain. The patient has had achy pain in her hands and feet for the last several months, which is worse in the morning. She says her fingers are stiff when she wakes up and she has difficulty opening the doors and holding spoons. The pain gradually improves over 2 to 3 hours, but the patient feels slightly fatigued throughout the day. Taking Brufen provides some symptom relief. Medical history is otherwise unremarkable, and she takes no other medication. Vital signs are within normal limits, and physical examination shows no rashes or oral ulcers. The wrist and fingers are swollen bilaterally and are tender to palpation. Laboratory testing revealing the hematocrit is 33% and serum creatinine is normal. The patient current condition is most likely to directly increase her risk to which of the following? First, we have to just make sure that what it is. Like there is a joint pain, there's a stiffness, and improves over 2 to 3 hours. Everything is normal. She's taking Brufen, which relieves her pain, and So I think so. It's rheumatoid arthritis, and it's bilaterally. And okay, fine. It's rheumatoid arthritis. Now, the patient of rheumatoid arthritis is at a greater risk for what? For what? Anyone? Anyone have any idea that rheumatoid arthritis are more prone to what? Okay, we just move. She is at a greater risk of generalized bone loss. And it's the extra, yes, it was rheumatoid arthritis. Extra articular manifestation of rheumatoid arthritis is fever, weight loss, fatigue, fibrotic lung disease, pleural effusion, lung nodules, pulmonary atherosclerosis, vasculitis, osteopenia, osteoporosis, rheumatoid nodules, and anemia, depression, neuropathy, joint syndrome, Raynaud phenomena, scleritis, and episcleritis. This patient has chronic systemic symmetric polyarthritis consistent with rheumatoid arthritis, which is a progressive inflammatory disorder that is more common in women. It usually occur at any age, although peak incidence is 30 to 60. Rheumatoid arthritis is characteristically associated with prolonged morning stiffness, and symptoms may be more noticeable in the dominant hand. Okay, in the dominant hand, and she was having the dominant hand because she was unable to hold the spoon and open the door. The most commonly affected joints are the metacarpal phalangeal joints, metatarsal phalangeal joints, and proximal phalangeal joints, wrist and knees. Extra-articular manifestations are common in rheumatoid arthritis, especially in patients with positive serologies, that is rheumatic factor, and all of the systemic features of the fine weight loss, fatigue, anemia are present. Okay, in addition to this, okay, fine. We just go. A patient with rheumatoid arthritis are increased risk of developing osteopenia, osteoporosis, and bone fractures. Management includes adequate physical activity, optimization of calcium and vitamin D intake, minimization of glucocorticoid therapy, and biphosphonate treatment. Okay, so the patients of rheumatoid arthritis are at risk of developing osteopenia and osteoporosis and bone fracture. And the management is physical activity, calcium and vitamin D intake. You will, it's got reduced glucocorticoid therapy and biphosphonate treatment. Okay, now another question is a 61-year-old woman comes to the office due to low back pain for last 2 weeks. The patient has a constant dull aching pain that is more pronounced at night and has awakened her from sleep on several occasions. She has had no trauma or previous back uh, conditions and attributes to the pain for to prolonged bending while gardening. There is no associated fever, chills, bowel bladder incontinence, or lower extremity weakness or numbness. Medical history is notable for hypertension and early stage breast cancer at 55, which was treated with lumpectomy, radiation therapy, and hormonal therapy. Okay, fine. The patient does not use tobacco, alcohol, or drug. Temperature is 36, blood pressure is 134 by 86, and respiration is 12, head, neck, cardiac, lung disease. No abnormalities. Spinal examination shows no deformities or focal tenderness. Lower extremity, motor strength, reflexes are normal and symmetric. Straight leg raising test is negative. Which of the following is most appropriate next step? The management. We have to manage this patient. Epidural corticosteroid injection, lumbosacrospinal imaging, opioid analgesics at bedtime, of supervised exercise program, trial of NSAIDs, and follow up. Anyone? So she's having a back pain for 2 weeks. It's constant and dull, and which has, she was unable to sleep because of that pain. no trauma or no other conditions, previous back conditions and attributes to the pain, prolonged bending over no, no fever, nothing. The patient is using nothing. She had breast cancer for which she was treated with this and that. Anyone? Any idea what we have to do next? Like how, what we would manage? This is the history. Like, it seems like the patient is coming to us for the first time and she's saying that, okay, fine, I'm having this. And now how we will manage this patient. In this whole paragraph, they have not mentioned that she has been taking any kind of the medications. So it's epidural injection. No, we will not start the treatment. I think so. We will go with imaging. First, we will do the imaging because she's 61-year-old. It can be because of anything. And, she had breast cancer also at the age of 55, which was treated this. But I have heard that, breast cancer, often treated breast cancer, it relapse also, it come back again. Uh, I've seen such cases also. One of my patients, she was having a breast cancer when she was treated for the breast cancer when she was, I think so, 45 years old. Although she breastfed all her babies, and at the age of 60, or I think so, yes, was she was I think so 60 or 63, she was having breast cancer again on her another breast. And the symptoms, it was so irrelevant that um, it was just of the UTI symptoms, and everyone was treating her for the UTI. Okay, so I will go NSAIDs also we can, but I think so we will, yeah, it can be NSAID trial, but if she's having this, there is no, okay, fine. I think so. It is, yes, it is imaging. Okay. Okay, fine. Indications for imaging low back, X-ray, osteoporosis, compression fracture, suspected malignancy. Okay, suspected malignancy also, and ankylosing spondylitis. Okay, MRI, sensory motor deficits, cardiac venous syndrome, suspected epidural abscess infection. We will do this and radionuclide CT scan indication by patient. Okay, fine. Most cases of acute low back pain have a benign etiology and spontaneous resolution. Imaging generally does not improve outcomes and is not recommended. Most cases of acute, okay, acute, and her case was 2 weeks. However, spinal imaging is indicated for patient at risk of infection, malignancy, or infection, malignancy, or bony abnormalities. Example, compression fracture. Red flag that warrant imaging include sudden onset of pain with spine tenderness, history of cancer, constitutional symptoms such as fever, unexplained weight loss, trauma, significant or progressive neurological deficit, elevated risk of spinal infection. This patient has features suggesting malignant back pain. Nocturnal history of malignancy that warrants imaging. Plain film X-rays can be performed quickly and often identify signs of malignancy. Inflammatory markers can increase the sensitivity and advised, and are also advised. Okay, inflammatory markers also advised. Okay, and then the this educational. Although spinal imaging is not recommended for uncomplicated acute low back pain, imaging is warranted for patients with suspected malignancy. Although it's not recommended, but if we are suspecting, we will do the imaging first. And infection of bone X-rays and inflammatory markers are recommended for patients with suspected malignant pain. MRI is indicated for patients with abnormal findings on initial tests, significant neurological deficits, or cardiac venous syndrome. Okay, question number 16. This will be the last question. We just do it quickly. We will just stop here and we will continue tomorrow, inshallah. Uh, what's everyone saying? Okay, we will continue tomorrow then.